professor of epidemiology here, and I am also the executive director of the CUNY Institute for Implementation Science and Population Health. And we are co-hosting this grand rounds with the School of Public Health this month. And I'm very happy and pleased to bring to you today our speaker, Patrick Sullivan. Professor Patrick Sullivan is coming to us from Emory University. I just want to start by saying I've known Patrick for many, many years, including when we were both at CDC together. And I mean, the first thing I'll just say about Patrick is how generous and insightful and helpful he can be with almost any technical issue that you might have the chance to talk with him about. And I've benefited from that, and I know my colleagues have benefited from that really beautiful attribute about him over the years. Patrick is the Charles Howard Candler Professor of Epidemiology at the Emory University Rollins School of Public Health. He also, before that, spent about 5 years as chief of the Behavioral and Clinical Surveillance Branch at the Division of HIV/AIDS Prevention at the Centers for Disease Control, among many prior roles at CDC, including as an Epidemic Intelligence Service officer. In addition to having his PhD in comparative and experimental medicine from the University of Tennessee, he's also a doctor of veterinary medicine from the same institution. Much of Patrick's research and scientific leadership is in the area of HIV prevention, and he has had multiple NIH grants and CDC grants that has supported really cutting edge research that has positioned him as a significant leader in the field of HIV/AIDS epidemiology in the US and globally. And he also runs the AIDSVu and HepVu websites, which many of you may have seen. These are web-based interactive mapping tools that really help to leverage county-level surveillance data for the entire US. These are major projects that serve as a critical resource to so many people working on those population health challenges. And like many of us who were busy working on other things last spring, Patrick has turned his attention to the COVID-19 pandemic, which is, I think, what we're going to hear more about today. So I just want to say, very personally, welcome to CUNY, Patrick. We're really happy to have you with us today. Thanks for being here.
Thanks, Dennis. Thank you for the opportunity and for the kind introduction. And I will say that I share the same feelings about a couple decades of working together around HIV issues, and just really enjoy the collaborations and happy to be here today. And I think Dennis's sort of lead in there was just kind of maybe the inspiration for the framing of what I'm going to talk about today, which is that when a new pandemic comes around, which I think we all feel like this is what we train for, is to be in response. And what we come with is the skills and the flavor and the kind of approach of the institutions where we've had the privileges to train and to work and to meet and know colleagues. So we bring all that stuff with us, and yet it is a new it's a new pandemic. And so figuring out how to take those lessons learned so that we can make progress quickly towards answering the epidemiologic questions and the public health questions is something that I think a lot of people who are working in the HIV epidemic and other parts of IDEPI have come to. And so it's been a pleasure to try and apply some of the things that I've learned and working with colleagues to the HIV epidemic and talk about how we've applied those to epidemic response. And so today I'm presenting on behalf of a number of colleagues, but the main COVIDVu project that I'm presenting on, I co-lead with Aaron Siegler from Emory's Department of Epidemiology. So what I'd like to do today is talk a little bit about some of the HIV-focused work that provide a little bit of the foundation for the COVIDVu work. And then I want to introduce the COVIDVu study, talk about the rationale and goals, the study design and procedures, and some of the materials. This particular study, which is a national population-based survey of PCR and serology for for SARS-CoV-2 has a significant laboratory component. And so we've done a fair bit of work on mail-out laboratory kits. So I'll talk a little bit about that. And then lastly, the sort of study website and dissemination and the idea of building on our AIDSVu and HepVu to COVIDVu, which is all of these sites, even AIDSVu and HepVu have a slightly different sort of structure and data that are offered, and COVIDVu different than that. But the idea that all these data that we collect through surveillance systems or through these kinds of studies are great at a national level, but they're impactful at local levels. And so the more local we can make these data and the more broadly we can make them available, the more public health impact we'll have. So I'm going to start by talking about some work that Aaron Siegler and I have been working on for some time around the idea of mail-out specimen collection for HIV. And so starting on the left was this idea that was funded in an R21 to try to, and the sense of this was like, if we really meet our goals to get a large proportion, 30, 40, 50% of the at-risk men who have sex with men in the United States on PrEP, that it's going to create a tremendous burden in the healthcare system of follow-up visits, because this intervention as daily oral PrEP stands now is to start and then to come back every 3 months for repeat HIV and STI testing, creatinine testing at certain visits, and that's what's needed to maintain that prescription. So if we really got the number of MSM that we need to get onto PrEP in order to have a population impact, we'd be adding 6 or 8 million provider visits into the US healthcare system just to do this follow-up monitoring. So the idea of PrEP at home was to develop and validate a system so that those follow-up visits for PrEP could be done at home. And the idea is that someone would start PrEP and have that first visit with a provider, but that the subsequent follow-up visits would come in a box to their house, and they could collect urine, self-collected rectal swabs, pharyngeal swabs, dried blood spot or microtainer for syphilis testing, and mail all that stuff back in. The lab gets the kit. That's correlated with self-reported adherence and sexual risk behaviors, and then the provider can review that and renew that prescription for PrEP without a visit having to come into the office. One of the things that we learned from that was around making these instructional videos to support men to be able to collect those specimens at home so that when they got to the laboratory, they were sufficient. Following on to that R21 pilot, Aaron is now working through the Adolescent Trials Network, through the UNC Emory Adolescent Trials Network site, to roll out this sort of completely home-based PrEP intervention to adolescent MSM, especially in rural areas of the South. And then Aaron and I jointly have received one of the MP3 mechanisms to incorporate some of these app-delivered prevention tools to Chinese MSM, which is the Blue D app over on the right. And I think that the lesson learned here is sort of bringing prevention to the people, and the importance of taking a systematic approach to developing these tools. So for PrEP at home, we did a pilot with these mail-out kits, enrolled 58 people, of whom 55 completed those assessments. And you can see the outcomes there, but we diagnosed 8% with gonorrhea, about a quarter with chlamydia, and no syphilis or HIV diagnoses in those. But at the top right, you can see that among the participants who used it, that, sorry, I got to move my box there. The dark green and light green boxes are some degree of agreement that they felt confident using the home collection kit, that they felt others would learn how to use it quickly, that they thought it was well integrated with the surveys, that they thought it was easy to use, and that they would use it regularly at pretty high levels. And so, and then we also asked the providers about their willingness to receive this kind of information as opposed to having the PrEP user come in for a visit. The lessons we learned were, that it's feasible to have high response rates for these complex multi-step specimen collections that we worked on developing specimen validation procedures for remote testing, that self-collection can be highly acceptable, and the value of the videos, which I'll show you in a minute. From the ePrep, which is the ongoing completely app-based prep, some of the lessons learned are human-centered design and using electronic data systems to make a unified user experience and really bring everything that's needed to the participants through this interface, and also the importance of appropriate messaging and reminders that can be done through these mobile apps. And these are some data that relate to the BLUE-D project. And the question here is, in these pairs of bars, comparing the proportion of Chinese MSM, for example, in the top line here, who use and don't use condoms, which is 46% not always and 54% always, and then asking among those who aren't always using them whether they would order condoms through an app. So we sort of look like a 50-50 condom use, but when you look further at the people who aren't regularly using condoms, more than half of them would be willing to order condoms through an app. Similarly, for HIV testing, there's 30% of these Chinese MSM respondents had never tested for HIV in their lifetime, but 2/3 of them would order a home test. HIV tests in the last 6 months, 67% no, more than half would order a test to test at home. A lot of men had not heard of PrEP, but among those who had heard of it, half of them would consider taking it if we facilitated it through the app. So the point is that that we can actually extend the proportion of people who are engaging, for example, in testing activities, at least by self-reported intention, if we offer them opportunities to do this at home. And I'll sort of wrap up by saying, are those sort of preferences for home testing similar for COVID testing? And these are work from a survey that Aaron Siegler led, this analysis led by Eric Hall, where we asked about different aspects of testing and people's willingness to test for the virus that causes COVID-19 disease in different ways. So starting at the top here, the home people, when we ask about providing a saliva specimen at home and mailing it in, 88% of people were agreed or strongly agreed that they would be willing to do that. And there were high numbers also for a self-administered throat swab at home, a little bit lower, 65% agreement for a blood sample. But compare that to being willing to go to a drive-through site for a throat swab, which was only 64%, or to go into a clinic to get a blood sample drawn, which was 57%, or a throat swab done, which is 53%. And I think part of what's going on here is, in COVID particularly, that people recognize that there's a risk to going into a clinic where some people are going in to be treated. And so some of this preference may just be that there's a safety element to being able to collect specimens at home. So I'll come back to the self-specimen collection of it in a minute. So the COVIDVu study, we aim to conduct a national probability sample of over 9,000 respondents to determine a cross-sectional prevalence of active SARS-CoV-2 infections by PCR and antibody response, and establish estimates and confidence intervals nationally and in certain populous states. So we're leveraging this experience in home specimen collection, being able to stratify by key covariates like race, ethnicity, underlying health conditions, symptoms, gender and age, and then to use a platform called COVIDVu, which is now up and running, to visualize and disseminate the study data. The second aim was to turn this cross-section into a cohort by doing follow-up testing with the participants to allow for an estimate of incidence calculation. And then third is to use mathematical models to estimate epidemic trajectory that's informed by representative prevalence and incidence data. And I'll come back to some of the sort of study outcomes. So as we were writing this and just getting this grant, the framework or the lay of the land for serological surveys in the US, had some pretty disparate experiences. So in New York State, you guys are probably well familiar with an antibody prevalence study It was a convenient sample of people recruited at grocery stores and community centers that had an overall 12.3% antibody prevalence during a pretty hot period of that early epidemic in New York. There's also a wide range of antibody positivity, but the highest was in the city, close to 20%. In Los Angeles County around the same time, a survey of 865 adults, they were described as selected from a proprietary database and had a 4.3% weighted antibody prevalence with sampling weights. In Santa Clara County, 2.8% weighted antibody prevalence. This was the study where there was probably substantial bias of people being encouraged to seek testing. So there are sort of varying degrees of bias in these. And part of the point is that, you know, from sort of a probability sample through this market research firm, through a study like the New York State study that aimed to reduce bias by recruiting at grocery stores so that people weren't seeking out testing by invitation, to the Santa Clara County study where there were considerable concerns about selection bias. That all of these have some degree of bias. And so we sort of felt like in the mix of this, that having a serosurvey that would incorporate probability sampling methods would add to that. So in terms of methodologic issues, this is an image from a piece that just came out in JAMA by David Stevens and Julie McElrath, you know, thinking about what we know about the antibody response. And so I will say that, which I'll come to later, is that we didn't really have the benefit of understanding, of this understanding of the immune response at the time we were designing the study. But, you know, just to point out that, that the idea of having both PCR and antibody testing means that there's some opportunity to detect a cumulative incidence by a combination of people who are infected and shedding virus even before they are antibody positive. And we're differentiating, as I think the study being led at CUNY is, between IgG and IgA as sort of late and early phase isotypes. And then the thing that we really had no way of knowing in April when we wrote and designed this study is just that this waning IgG would become a major methodologic challenge to developing estimates of cumulative incidence using serology. So I'll come back to that. So what are the methodologic issues in assessing antibody prevalence or cumulative incidence? You can think about populations, which is that when we have non-probability samples, those can often be enriched for people with symptoms or exposures or who are motivated to be tested. Just the natural history, the waning of antibody titers, and that really complicates the interpretation of serology as a marker of cumulative incidence. There's a methodologic issue and an implementation issue, and that there's disproportionate impact in Black and Hispanic communities and individuals. But as I'll show you momentarily, there are also challenges, as there have been in HIV research, with ensuring adequate representation of certain racial ethnic minority communities in research. And then, I think one of the issues in assessing this is, potentially the reluctance of well people to attend clinical research sites, which may bias, again, towards people who are more motivated to get tested. And then there are issues of test performance whenever there are rare outcomes. And we know that depending on the epidemic phase and the intensity of epidemics, that the antibody responses may be down in that single-digit % range, where you worry about the predictive value of positive tests. So the design that we proposed uses address-based sampling with a sampling frame that includes nearly all addresses in the United States. One of the benefits of this kind of sampling frame is that it allows for waiting for non-response and adjustment. Address-based sampling, I think, in a sort of purist way, is one of the rigorous ways to get population samples. We're developing and using home specimen and remote laboratory testing procedures, which, as I showed, has higher acceptability than in-person specimen collection. And we can reach otherwise hard to reach populations, like people who are working and may have challenges with attending study visits during the day, and people in rural areas. We're using confirmatory antibody testing. So we're using that classic, high sensitivity screening test followed by a high specificity confirmatory test, and using tests that target different antigenic components. And this should resolve specificity problems for testing in lower prevalence populations. And we feel like performing both viral detection and antibody testing provides a simultaneous understanding of potential infectiousness and potential immunity. And this sort of addresses the issue of antibodies as a lagging indicator. So we published the protocol for this national probability survey, as I'll talk about in a minute. I really like the trend towards publishing protocols up front, but especially in a quickly emerging epidemic, I think it brings the challenge of that the ground kind of shifts under our feet. So we already have had to make some modifications, which I'll talk about. But here's our original conception, which is we start with the United States population. We target 4,000 participating households initially, and we mail out to them an introduction letter, and then we mail out to all of them a collection kit. So we don't wait for people to say that they want to participate before we send them a kit. That's an anterior and area swab for an RNA-PCR and DBS for serology. Those specimens come back to a central laboratory. The test results are returned to the participant through the online laboratory portal. And then we use those to develop estimates. And then we'll go back again to those same participants and ask them to resample in 3-month intervals so we get these estimates of incidence. In terms of the powering of this study, I just want to point out that actually with this kind of address-based sampling, that a sample size, we're sort of aiming for 4,000 responses, but you don't get a lot of marginal narrowing of your confidence intervals going, for example, from 3,000 to 4,000. Part of the reason that we chose 4,000 is because they're important subgroups that we want to be able to get meaningful estimates within those subgroups. But actually a relatively modestly sized sample, 2,000 to 3,000 at the whole country level actually gets you a pretty precise estimate. And these are for different levels of prevalence of the outcomes. So these are the kits that we mail out. Screening survey and consent, we enumerate the household, so we know how many people are in the household and their ages and sexes, and then we randomly select one of the adults in the household to be the person who completes the kit. The kits include instructions. I'll talk a bit more about these in a minute, but I would just reiterate that part of what's really important about this is there's a lot of work that goes into developing the kits, the components, the instructions, and testing them with potential participants so that we really understand that the specimens are being collected in a way that's going to yield meaningful results. And I'll talk a bit about some of the modifications of these, but these are the printed instructions. And then what we found in the sort of Prep at Home project was that if we observe people using these specimen collection tools, that there were common errors, and that we could produce a video that uses humor to emphasize some of the common mistakes. So I'm going to play these two videos for you back to back, the nasal swab and the DBS. And I'll just say, like, for example, in the DBS collection, the problem is that people want to touch their finger to the circle DBS card. and put the blood on by touching it on the circle.
Not at all. Can I open the back door? Or do?
So you'll see how we really called out and try and emphasize.
Beverly, can you please mute? Sorry, Patrick. I'm going to ask everyone on the line to please mute, including Beverly Schwartz.
Okay.
Okay.
All right, no problem.
Here's the first video for nasal swabs.
Looks like somebody's got a package. It's your home COVIDVu test. Hey, you need that. Review these instructions to ensure an accurate test. First, fill out the questionnaire to make sure the right person in your household is taking the test. Then finish the survey. Remember to register if you want to get your results. Time for the nasal swab. Fill out today's date and your birth date on the collection tube barcode. Wash your hands with warm water. A, B, C, D, E, F, G. You know how to wash your hands. Remove the nasal swab from the wrapper. Careful! Do not touch the cotton tip or put the swab down. Hold the swab 1 inch below the cotton tip. Perfect. Now insert the swab a ½ inch into your... You can take that off now. As I was saying, insert the swab a ½ inch into your right nostril and rub all around the walls for 10 seconds. 1 Mississippi, 2 Mississippi, you should count to 10. Get a good solid rub. Repeat with your left nostril. Twist the cap off the collection tube, being careful not to spill the liquid, and don't drop the swab. If you spill the liquid, your test might not work, so contact us to request a new tube. Put the swab in the tube and break off at the indentation mark by bending against the edge. Twist the cap on the tube until it's nice and tight. Place the capped and labeled collection tube into the biohazard bag and seal it with the absorbent sheet inside.
All right, and then we're going to move on to the DBS.
Looks like
the DBS collection. And here again, we really call out some of those common DBS errors. I think you'll be able to see where.
For the blood test, begin by filling out your information on the collection card, being careful not to touch the circles. Then wash your hands with warm water. Now, shake your hand below your waist. Shake your hand below your waist. Yeah, get the blood moving. Now, wipe your hand with the alcohol wipe. Don't blow, just let it air dry. Brace your finger and push the lancet into the side. Now, milk that baby. Wow, shaking your hand really made that blood flow. You're doing great. Drop, don't blot, and fill the circle. It's okay if blood goes outside the circle. I said don't blot. Use more than 1 drop if needed. Stop, don't cover it. Allow the card to dry for 15 minutes. Now put the card into the biohazard bag. Make sure the desiccant is still in the bag. Return the biohazard bags into the box. Mail your test back to us. The box will fit perfectly in the mailer. Feels good, doesn't it? Thank you for doing your part.
So I'm going to move on, and we really talked about earlier on. One of the lessons learned was trying to bring all the kinds of information required together to make that convenient for the participant, but also on the management side. So this is just sort of a schematic of how the data system for this study is designed, that has a central cloud-based management platform. Our staff at Emory are interacting with a lot of inputs and components. I'll show you our study dashboard. But then the folks who do the sampling are integrated into this, our call center, our lab portal, the web-based survey platform, and then the electronic gift cards to the participants are also all controlled through this central system. And this makes it feasible to do this sort of large volume of research efficiently. I want to show you, this is an example of one of the dashboards that we use to monitor. And this is just the top part of it. But we can look at things like completed surveys, enumeration surveys, how many incentives have been paid, positive results that are reported by WAVE, and breakdowns by state, et cetera. So you can see, we're sending out some pretty substantial numbers of kits. And all this stuff is dashboarded for study management. This shows some of the demographics that are pulled in from the surveys. I'll come back to this point. that we're working really hard to increase the participation of racial and ethnic minorities. Our average age currently is about 51. So I'm going to turn now to talk about the laboratory studies. This really was, to be able to do a nationally representative study like this, there was really no alternative but to use sampling methods. And so this, for me, drew on experiences at CDC setting up a surveillance system for clinical care outcomes for HIV called the Medical Monitoring Project. But in this case, we don't have the people in care already going into clinics, and so we had to mail out specimens. And so the goal was to develop a viral detection assay and a serology system, thinking about like moving towards EUA. These are done in a research setting, so they're with consent, and they can be done pre-EUA with consent. We have to think about self-collection, the stability of specimens, the acceptability of this kind of testing, and the predictive value of especially positive test results in the setting of low antibody prevalence. So I want to just go through this thought process, which was in a very compressed timeline, again, learning from the prep at home work, which was, are people willing to use kits? Can they collect sufficient samples? Do they find the process acceptable? And will people collect again after they've done it once? Because we want to come back and resample. So we did a study where we actually mailed out these test kits and had medical providers have telehealth meetings with participants and watch participants collect the specimens as a first phase. I've already shown you these data from the survey that Aaron Siegler led, showing that the intention or the stated acceptability of at-home collection was high. We next mailed out these kits and had them observed by providers. And what these data show are for a DBS card, for an oropharyngeal swab, and for a saliva specimen, the proportion of the specimens that medical providers observing through telehealth felt were sufficient. So that 93% of the DBS cards, the providers, these are nurse practitioners, physicians watching, felt like were okay to use for lab testing. 96% of the OP swabs and 97% of the saliva specimens. And when they got to the lab, we did assessments of sufficiency, which is for DBS cards, the number of circles filled and the dryness. For oropharyngeal swab and saliva, using the RNase p-values to show that there was sufficient biological material. So whether it's a physician's assessment of whether the collection looked good, or whether it's a laboratory's assessment of the acceptability of the sample, the sufficiency of the sample, the swab studies looked really good, and the DBS suffers from this problem of not enough usable spots is its main limitation. In the study that we're fielding, we're finding much better than 72% of the specimens actually have sufficient specimen to do that initial antibody testing. When we asked participants about how acceptable it was to the components of this process, the blue plus orange indicate the very acceptable or acceptable. So all of these except for ease of packing specimen in this at this stage of the evaluation looked quite good. People found them acceptable or very acceptable. And the one thing that didn't work well was ease of packing specimen. And what we found was that between when we designed the kits and when we started shipping them, the United States Postal Service had slightly decreased the size of that poly overwrap that we were putting the kit into, and the kit no longer fit. And so we had to go back and redesign that piece. In the video, because we'd gotten these complaints, it says like it'll fit just perfectly, which after we redesigned things, it did. But this was an important step because it really identified for us a problem that we hadn't anticipated that could have been a big barrier to getting back acceptable specimens, or they wouldn't fit in the return shipper. And finally, after people had collected these specimens, we asked them about essentially the acceptability of the process and whether, with the idea towards would they use it again. And so having done it, 85 to 91% of people said that all components of this, were quite highly acceptable. So the current status of PCR is that we're using anterior and area swabs that are self-collected and using an EUA, Thermo Fisher EUA kit, so that once they get to the lab, they're tested with an EUA PCR platform. Anterior nares swabs perform well as a specimen type. You guys have probably also lived through the progression from initially, these very deep nasal swabs that were quite uncomfortable to get nasopharyngeal swabs. And FDA has subsequently approved self-collected mid-nasal turbinate swabs based on a study from Kaiser in California. And CDC recommends self-collected anterior nares swabs, which have quite high sensitivity. To validate this, we actually did a study where we observed 252 participants who had, I think, about a 20% prevalence of PCR positivity. And we had them collect a self-collected nasal swab, and then we had a provider collect a self-collected nasal swab, and we compared those to each other. And then at FDA's request, we did a human usability study in August to September to ask about every step in the clarity. So the EUA path here, we've completed this acceptability usability study. We've submitted the EUA in early September and submitted responses and a revision in mid-September. It's the current status is, I think that there's some prioritization of new test systems for labs over new collection methods. So at this point, we are still without an EUA. With respect to the instructions, I'll just mention that this was an original version of on the left of the collection instructions, and you'll see in panel 3 that this is how we showed holding the swab. When we did this study of 252 people using these instructions, what we found is that many of them would hold the swab literally as we had shown it. This is my Apple Pencil, but they would hold the swab like this and then try to get a good level of sort of friction against the nose, but it's hard to do because the fingers are so far away. So in the revision, so that's the original. In the revision, we actually moved that up, and then in the video, you notice we specified the 1-inch material, or the 1-inch interval. Although these original instructions said repeat in the left nostril with the same swab, we found that when they were just using these instructions, many people just did one nostril. And so we both emphasized that in the video, and we made that revision of the instructions. There's a lot of sort of like person-centered design here to be able to make sure that the specimens are rigorously collected and perform well. I mentioned stability, and one of the things that FDA asks us to do is to make sure that these swabs, when they're sent back through the mail, don't lose any of their diagnostic value. And so they have summer and winter profile, temperature profiles. So this is a summer profile. And to simulate shipping in a summer season, what the lab does is take samples with known levels of virus. And you can see here, those are 10 times, 5 times, and 2 times the limit of detection and 10 negatives. And they put them through a cycle of 40 degrees C for 8 hours and then 22 degrees C for 4 hours. And you can see the rest of that table. And this simulates, sitting in the tarmac of Memphis Airport because you're coming by FedEx, and as a way to ensure that the shipping process doesn't lessen the sensitivity of the test. And then what we're looking for essentially is the stability or degradation of these 3 targets that are for detecting the virus itself, these 2 control assays which detect the presence of human, like human biological material, and the level of detection, the amplification rate for those. In terms of serology, we're using DBS specimens with a 2-step algorithm. The first step is the Bio-Rad total immunoglobulin, which evaluates for IgG, IgM, and IgA. The second step is the Euroimmune, and there are 2 separate assays, one for IgG and one for IgA. And the point of using this algorithm is that in low prevalence situations, like with a percent prevalence, if the assay, the Bio-Rad assay, performs as at the level that's estimated by the FDA, so the FDA publishes a sort of central measure of central tendency for sensitivity and specificity, but also 95% confidence intervals. And so what we find is when we put together these 2 assays, even at a 1% prevalence, the predictive value of positive and negative tests is very good. If you take the worst case, which is the lower bound of the 95% confidence intervals for sensitivity and the lower bound for the specificity of the confirmatory test, even at 1%, you're still getting an 81% PPV. You're as low as 0.1%, you're going to have significant problems with positive predictive value. We're sort of falling up above between the 2 and 5% levels, and so we feel like the performance of that algorithm is pretty good. We've evaluated 372 serum DBS pairs for validation, and then submitted validation sort of comparisons. And so this is for the sensitivity and specificity of these tests relative to serum. It's sensitivity relative to the serum result, and the DBS results basically perform equally well. So I'm going to move to dissemination. We have a COVIDVu participant site. This is hosted as a subdomain of our Emory site. I think there's pretty good research to show that the trust in these kinds of informational sites are higher if they're associated with the university. This is really for participants to provide instructions. They can access the videos that I just showed you. You can access the videos if you want to see them online. This is under the Watch tutorials. Information about the study, the test kit, FAQs. It's meant to interact with participants. So that's the participant site. It's up and running now. We have launched in several waves, which I'll show you. I think we'll have our first stable estimates launched towards the end of this year. A few lessons learned about dissemination is just through our through our AIDSVu site. So the COVIDVu public site, once we get results up and ready, will be modeled after our lessons learned from the AIDSVu site. And so this site will be used to disseminate data rapidly, to make data sets available for local analyses, to provide state health departments a place to display main results and share study materials. And so we'll think about these this is a screenshot of our AIDSVu site, about like what are the tools and resources, downloadable data, infographics to quickly communicate disparities or regional trends as you see here. And we'll use a lot of those lessons learned from the AIDSVu site. We also will be able to display more local estimates. It won't be down to the county level like we do on the AIDSVu site, but in some states like Georgia and California, where we're going to have sufficient numbers to make sub-state level estimates, we'll be able to map those and combine them with other data about prevalence and other indicators. And again, this is just an example from our AIDSVu site on the right, where we sort of show things like the distribution of the state population by race ethnicity, and then you can compare that to the distribution of cases within a state by race ethnicity. These are some of the primary outcomes that we're anticipating, and just and what we think the power will be. So for the period prevalence of either antibody positivity or PCR, at a national estimate, if the mean is 5%, that will be sort of plus or minus 0.7%. In subgroups like age, we'll have confidence intervals that span around 1.5%. For men and women, about a plus or minus 1. If you think about a subsample in a state like New York with a 2% prevalence, your confidence intervals get pretty wide in subgroup estimates. And then just as an epidemiologist, thinking about once you have these national numbers around number of people who have who are either shedding the virus or have immune experience and who say that they've been diagnosed or who had symptoms or not, then we can derive a lot of things like the estimated proportion of SARS-CoV-2 infections that lead to diagnosed CoV-2 by comparing the total grand N of infections to the diagnosed infections in the US, or ask the question about what proportion of SARS-CoV-2 cases are asymptomatic or mildly asymptomatic, and a variety of other epi measures. So our progress to date, we have gotten IRB approval. We've validated the tests as I showed you. We've drawn our national sample, and we've gone through several waves of enrollment. We did 200 households as a pre-pilot, followed by a wave of 2,000, and we've now done 3 full waves, and this will be the last this wave 3 is the last wave of the baseline sample. What you'll notice is in waves 2 and 3, we've moved to adding minority oversamples for a reason that I'll tell you about soon. Another lesson learned from HIV that I looked back and realized that I was working on this in the early 2000s in a different setting, which was HIV vaccine research. This paper led by Gaston Jomon just documented the challenges with enrolling racial ethnic minorities in NIAID-funded networks for HIV vaccine trials. Similar pieces have been done and updated more recently about participation in HIV/AIDS treatment research and in other kinds of and more recently in HIV vaccine trials. So in terms of some of the challenges we've encountered, we've had lower response rates to these mail-out kits than we planned. We planned for 50% when we submitted the grant. We sort of felt like at the time there were real gaps in testing and that people would be motivated to be tested. What we've ended up with is more like 18%, which is typical for these kind of household-based cold email sampling surveys and can be adjusted for. But we have had to increase the sample size of the mail-outs. I would just point out that our sort of 18 to, I think we will hopefully get close to 20% response rate is similar to other probability surveys. CDC published a study in Atlanta and another study in Indiana where they actually sent people out to houses that were randomly selected and offered kits, and they got just a bit over 20% response rate. So these response rates are low compared to other designs, but are typical for this kind of sample survey research. We also got lower than expected responses from racial and ethnic minority households. So for Hispanic participants, sort of 2/3 lower than we would have expected. For Black households, initially 80% lower. We've received funding from the CDC Foundation to implement a qualitative assessment where Heather Bradley from Georgia State University is actually taking teams of MPH students out and going to households that we know we mailed a kit to and asking them about if they got it, what they thought about it, why they didn't choose to do it. Some of the reasons that are coming out of that are probably well reflected in a newspaper story that was done after the CDC survey, where a local Atlanta newspaper went out to or was contacted, I guess, by households that had been approached and then talked to those folks. And what was reported in the paper was that there were concerns about the government having DNA and just the intimidation of having people in PPE approach their houses. But I think that the issues about medical mistrust, about mistrust of the government, about our sad Southern stain of the Tuskegee, atrocity, still weighs heavy on recruitment. So in response, we've developed a community advisory board. We've more than doubled the incentives to complete the survey for racial and ethnic minority households. And we've been oversampling of households in racial and ethnic minority census tracts fairly substantially. Those weights can all be taken into account once we get all the data in, but we feel like it's critical to have equitable representation of these communities in the study. I've already mentioned that one thing that we couldn't have known when we wrote the grant in April, and no one had been living with COVID long enough to know what was going to happen with these antibodies. But it turns out that especially for asymptomatic cases or mildly symptomatic cases, that antibody levels wane and may become undetectable. So our team is working with modeling solutions to figure out how to account for that. We've had problems with low participation rates. We've increased our sample size. And then the interpretation of the results ultimately, I think are going to be more along the lines of cumulative incidence once we have done these modeling adjustments for waning antibodies. So we had originally planned for 8 to 10 weeks and about 4,000 responses in our first wave. It's going to end up taking about 20 weeks to the first estimate, and we're going to end up with about 3,000 participants. We've already found that about 2/3 of those screened IG positives confirm with IgG. And so the idea that a fair number of those total immunoglobulin positives may be false positives seems to be borne out. We'll adjust for waning antibodies into the first release, and we think that probably will be done in December and hopefully published in Q1 of 2021. And so these are just, I'll just close with some of the publications. A lot of these are along the lines of the lab work and the willingness work, some of which we did in preparation to submit the grant. And I just want to say, I've mentioned these names throughout, but Travis Sanchez, Ben Lopeman, Mansour Fahimi, Charles Saley in the lab, Martin Franco is a sampling statistician, Colleen Kelly, Heather Bradley, and our colleagues at Emory have just been, I mean, this is really team science. And I especially want to acknowledge Aaron Siegler, who was sort of led a lot of these early pieces of the mail out instruction development and who co-leads this project with me. So I'm going to stop, and I think we have some time for questions, and I'm happy to just read some of those out of the chat window. So I'm going to go back to the earlier questions first, and people can feel free to continue to put questions in. There's a lot of great questions. All right, so the kit materials are available in Spanish, and I think, you know, if we move this into broader, I know that for California, where we're doing sort of a full statewide sample, they normally put out public health materials in a much larger number of languages than that, but we were able to do Spanish. Did we have to get permission from Outcast? I'm not sure I understand that.
It's part of your video soundtrack. I picked it up too. It was fleeting, but it was a great choice.
Oh, okay, thank you. Yeah, that's our good question. We have a contractor that we work with who develops the videos, Ori Salzberg, who handles those decisions, but I'll have to ask him if we have permission. We're not making any money off it, so that's one thing. I'm happy to talk with folks if they want to talk further outside of this. So if you just email me directly, I'm patrick.sullivan@emory.edu. We do have Spanish versions of instructions and videos. Those all should be on the website as well. If you want to go to the COVIDVu website. Are the teams being sent out to follow up? The question is, are the teams that we're sending out to follow up with folks reflective of the populations we're trying to engage? And the answer is yes. And one of the things that I love about our partnership with Georgia State is that Heather Bradley is an amazing collaborator, also a former CDC colleague, but also that the Emory and the Georgia State MPH programs really have different compositions of students, and Georgia State has a higher proportion of students who are from the Atlanta area and from the South. And so these were students who are reflective of the communities we're trying to engage. And what efforts are being made given the lessons learned to address mistrust? I think we're still sort of working on what the mechanisms for that are, but we've considered things like trying to get influential sort of endorsers that may even need to be more local to sort of speak to the importance of this research in the communities. And again, speaking of lessons learned from HIV, the success of programs, for example, to offer HIV testing through churches and through other trusted community messengers has been an important strategy in the South. Someone said we never had a second or third wave as people seem to think. The second wave will start around November. So I think I was talking more to the waves of the kits we've mailed out, but I do think that I agree with you that we're having kind of a smear, but there's going to be a clearly, there's going to be clearly going to be a third hump here, and so we expect to sample sort of into the sort of up to the beginning of that, and then come back for another round later. The transport medium for the swabs is just PBS, so it's not poisonous if someone drinks it or gets it in their eyes. I will say that other folks are just using dry swabs and putting them in tubes, and that seems to perform well. The folks at the Seattle Flu Study, I think, have been using that method. So it really doesn't seem to take a lot of preservative, and the transport medium is not toxic. SOGI data collected for the national probability sample, yes. and then we use the weights to weight those up. And I'll say, I mentioned that on our very first sort of oversampled, no differential incentive round, we were running 2/3 below the population prevalence for Hispanic respondents and 80% below the population prevalence for Black respondents. We're creeping back up above half of what we would expect for both of those, but this last wave has a substantial minority oversample in it. So I think we'll get close. Yes, we're definitely working with sort of community, with folks in the community, and thinking about how to make this credible. What are the implications for false positives among mass campus screening programs in low true prevalence settings? My feeling is that it's more so for antibody testing than for PCR testing. My son goes to a school where they test everyone, every student, every instructor, and every worker in the food service and the bookstore, everything, every week. But they're PCR testing. And I do sort of feel like, based on the performance of the test, that there will be some level of that. But I feel like the antibody testing really has more potential in terms of false positives. And so this is a lesson from HIV, which is when that first EIA rolled out and was being used for population screening, the prevalence was so low that the predictive value of a positive test was like the one piece of news is that your HIV test was positive, but the other piece of news is it's almost certainly wrong. You know, like that level of lack of confidence in a positive test, if this is done broadly with tests that have those problems with but specificity, then a two-test algorithm should probably be used.
Hey, Patrick.
Yep.
This is Dennis. I was so first of all, thank you a million times for like presenting all this like really important formative work and getting this important study launched. I think it's going to be an important national resource for us, and hopefully can lead to a lot of insights. I was wondering if you could say, in addition to the specimens, like what other data are you collecting, not necessarily directly related to COVID outcomes, but other things that we know are happening in households and communities, mental health, economic impact. What else is being collected from your participants?
In the first survey, we have quite a bit about patterns of behavior, mask wearing, hand washing, and I think that may be useful, on an individual level to correlate with risk, and definitely information about occupation and sort of the. This was designed in May, and so I think there's a lot of issues that are emerging. I think we will be doing more in the follow-up rounds of surveys to incorporate some of these emerging issues. But there's definitely it's this tension between like wanting to get a high response, as always, between wanting to get a high response rate and not overburdening people. But I think especially when we have people coming back for a second time, they're a little bit more invested. We plan to collect more of that. But there's a fair amount. I think we list the domains in the paper, but I'm also going to share if people want to know sort of what areas we're looking at. But that sort of hand washing, social distancing, like at the individual level, we definitely have those.
Okay, great. And was also wondering about, so you're getting this cohort set up. Do you have a sense of the longitudinal engagement yet? Have you had any sense of like what the repeat specimen provision rate might be?
Yeah, no guess yet. But we'll know more about that in the first couple months of next year.
Okay. Well, we're getting close to the hour. We're past the hour, and I do want to thank again our speaker and thank everyone for joining us today. And he's generously answered so many of your questions and is available offline as well. So thank you, Patrick. I really look forward to following this cohort, as you know, and seeing what kinds of great insightful information you'll be able to provide, and also look forward to our ongoing collaboration across the different cohorts around COVID. I hope that next time we can have you back, we're in a very different place and we've gained a lot of new insights about how to manage this pandemic and future ones.
And we all
Thanks
need
everyone for being here.
going to happen when we start getting vaccines for another call.
Right. Thanks everyone.
Have a good weekend.